Good afternoon, and thank you for joining us for today's webinar. This afternoon's presentation is being hosted by Transitions Matters, a program of the Family Support Center of New Jersey, and presented by Wendy Davis, Supervisor of Community Services Unit for the Children's System of Care. Before we begin, let's take a minute to go over how you can participate during today's web event. You each have your own control panel in the upper right corner of your screen that looks similar to the one here. Use the orange arrow to open or hide your control panel. To listen to the webinar, you have two audio options to choose from: mic and speakers and telephone. If you can't hear well using your computer speakers, you can elect to use your telephone to listen to the webinar. In order to maintain the best sound quality possible, all but the presenter will be muted throughout the webinar. If you have questions or comments, you can submit them using the questions panel. We will try to get to all questions at the end of the webinar as long as time allows. At this time, I would like to introduce Wendy Davis, the Supervisor of Community Services Unit for the Children's System of Care. Wendy, welcome.
Oh, thank you so much, Melanie. I appreciate you having me and giving me the opportunity to share about mobile response. I just want to make sure everybody can see the presentation.
We can, thank you. Yep.
Okay.
Perfect. Thanks.
All right. Okay. I will just start by sharing our mobile response and stabilization services mission and goal. And you can see here printed on the screen, we are a service that helps families with youth who are experiencing emotional or behavioral crisis. And we really try to do that by interrupting the immediate crisis. We want to help ensure that youth and families are safe. Our program provides supports and skills necessary to help return youth and families to their baseline or typical functioning. And really the goal is to keep the kids in their home or their original placement and in their school and in their daily routines, because we know when these ties are maintained that kids do better. That's where their strengths are built and that's what they're used to. And if we can maintain that, then our outcomes look better for kids and families. And this is in line really with our entire children's system of care objectives, as you can see. I'll begin by talking about some of the mobile response program elements and wanted to just review our program eligibility. It is a fairly broad eligibility. As you'll see here, we do serve youth up to the age of 21. Youth 18 to 21, we ask that they've been involved with DCF or a system previously. And that is, like I mentioned, very broad, even inclusive of kids accessing services and supports at school. We do require parent or guardian verbal consent at the time of program access to be able to provide a mobile response dispatch. And at the core of our program, really what we're looking to do is help families and kids, help any kind of escalating emotional or behavioral needs. And certainly the mobile response program was designed to help with burgeoning issues in the moment. Really it looks at kind of the past 24 hours in terms of timeline. However, we do see youth who have been experiencing challenges that have been building up. So it doesn't necessarily have to be that something happened that day that was exacerbated, that got to such a point that you needed somebody immediately to help calm things down. We have seen that, and we also have seen kids who may have been, say, more withdrawn over the past several weeks, right, and it just is kind of a decline. Or kids who have decreased in their communication ability despite having some communication ability, but it has kind of stepped down over the last few weeks. So I think that's really important to understand. When the system was originally conceptualizing mobile response, we thought we would see kids who were really at that high level, who really were kind of one step away from screening, and we absolutely do see those youth. And we also found that we see a lot of youth and families who have more moderate needs, right? That's something that we learned as we stood up the program. Perhaps the most important piece of our program eligibility is the family-defined crisis. And I did go ahead and pull in one of our slides from our mobile response orientation. It seems very simple. We do spend some time talking about what is a crisis, and we do that really to bring home the fact that what's a crisis for you or may not be a crisis for the next person in the room at that particular moment. So we talk about it in general as this: when we get off kilter, when we aren't able to function in the typical ways that we function by accessing our typical problem-solving skills or how we typically cope or settle ourselves down emotionally. Right? And our role as mobile response is really to help families and youth get back to being able to access those abilities. They're inherent in folks and sometimes just not accessible. I talk about frequently for myself in life, right? I had a father who had a serious health condition. I was about to have my third baby. My husband broke his ankle, right? So all of these things are piling up in addition to everything that goes on in life in general. But it was really forgetting to kind of buy a loaf of bread or, whatever it is for dinner that night that kind of sent me over the edge, if you will, that sent me into that crisis. Now, maybe buying a loaf of bread in a different context wouldn't be such an issue. But, for me that day, let's say, that was really what started my thoughts going. And I think it's really important to understand when we do train with the mobile staff, we talk about crisis models and how we all live in this state of sometimes in our lives being off kilter, right? We have things that we have to deal with. And certainly from seeing some of the days in the life and just barely beginning to understand what some of our families with kids, of course, with mental health challenges and kids with developmental challenges are going through every day, just as a matter of course, can really start to appreciate that any additional change can really bring us to what we talk with the mobile response staff about in terms of that trigger that shoots us up into more of a crisis state. And we go on to discuss sort of what the behaviors and emotions and cognitions of folks in the crisis states look like. And I think we're all very familiar. We ask the staff to think about themselves or someone that they know closely who has been in a similar situation to really relate and begin to understand and be empathic to these situations just from a starting point. We can really start to see, right, what that looks like and then what different things might be helpful in terms of intervention. So that's just a little bit about what we talk about with our mobile response staff, what a crisis is, and why it's so important for us, for the mobile response staff, to understand all of the contexts that are going on in our families' lives, and then the tipping points or the triggers, if you will. We do have a more formal clinical criteria, which is basically what I just described to you, and you can access that on the Perform Care website if you're interested. And that just sets out, again, the ages that for eligibility and the circumstances in which mobile response would be dispatched. I have a note here that talks about special populations and system merge. And I'll just say a very brief word about this. So back in 2004 was when our system had a pilot to serve youth with dual diagnosis. We started in Burlington County. And I mention that just to show what a long way we've come, even though I know, we have a long way to go. System development is wonderful and takes time, and there's bumps and certain successes, but it's from that point at which we started in Burlington County to partner with providers for kids who had dual diagnosis till now at the point we are with integration and serving all of our youth in the children's system of care has been a great success in my mind. And our system merge, Mobile Response, additionally had an opportunity several years ago. I guess it was in 2006 when we first, probably 2005, when we first began to merge with our family crisis intervention units. And not every county has done that. We really that was left up to county choice. But it was a huge undertaking given all the different systems that were involved to have our family crisis intervention units. Some of the counties choose to merge those with the mobile response programs. I don't know if anybody's familiar with family crisis or not. Briefly, it is a program that every county has. It's regulated by the AOC. There's a law regulating it, and it really helped the state begin to look at kids who had status offenses, runaway behavior, truancy behavior, juvenile family conflict in a little different way than bringing them into the court system. It really helped the state begin to look at them as in need of treatment and support and care around those challenges. So as you can see through the rest of our presentation, or maybe from what I've already said about the population that we serve with mobile, they're very similar. So it was a nice marriage to be able to merge them in certain areas. And there are a couple of things that are different with those programs. I mentioned needing parent consent to access mobile response just a few minutes ago. In the counties with the merged units, our law enforcement and our court personnel can also access the mobile response services if the parents are not available. Okay, just continuing with our program elements, I wanted to talk a little bit about access. For all of our children's system of care services in New Jersey, we do have one single contact point, and that is our Contracted Systems Administrator that you may hear called the CSA. Currently, that contract is administered by Perform Care. Excuse me. And that is the access number there on the screen. So for any service, when you call, you'll receive a menu, and you can select from anywhere from having an urgent situation, right, which you would press and be directed directly to a clinician, or perhaps you need a less urgent service, and you may speak to a member services representative first, who might take some demographic information and get your youth into our computer system, which is called CYBER. It's really an electronic health record that most of our providers can share and access most of the information in there. If you are calling for mobile response, or if you speak to a member services representative first and they begin to listen to your story and realize that you perchance could benefit from mobile response or even some other type of assessment, you'll be connected with, or in the case of pressing prompt, I think it's directly to one of our clinicians. And they are licensed folks in the mental health field. And they will just ask a few questions to begin to understand the needs of your youth and your family. And they'll ask things in the area of, risk. What's the current risk? Tell us about what's going on now. What prompted you to call right now versus, say, a week ago? They will ask about symptoms. So what's your what is your youth experiencing. They'll ask about your own needs. So how are you managing this, and could you use some help in managing this challenges that are happening right now. We did add some pieces when we had the transition from DDD to CSOC and the substance abuse services to CSOC. So they will ask some questions around those areas as well. Okay. And we know with families and mobile response, it's complex, right? We mentioned, one person's crisis just a little bit ago, and with a family and a youth, you have multiple people who are responding and reacting in different ways to the challenges that the youth might be having, right? So at that point of clinical triage, once they've gathered information, and you may very well be asking for mobile, but some folks don't know about mobile, so either way, if you're asking or if it's identified that it might be beneficial, the program would be introduced. Say mobile response is available. It is a 24/7 program, and they are designed to come to your home within an hour of the call. There is some leeway there. We find that some logistics come into play. So you can talk with the mobile response staff. For instance, if you are at work and the youth is at school and you'd like to meet at your home in 2 hours because you can't get there before then, that's absolutely fine, and they'll work that out with you. But we do kind of put a limit on it because we are a quick and urgent intervention service, that it wouldn't be outside of a 24-hour period, and they're not really scheduled appointments. Calls keep coming in, and sometimes if you do have a delayed dispatch time, they may get shifted a bit depending on the nature of the other calls coming in. So they've gathered the information, introduced the program, gotten verbal consent for the service. The care coordinator, or the licensed person at the CSA, will do a conference call, or what we call a warm line, with the local mobile response program. We do have 15 programs in the state. We have 2 tri-county areas in Hunterdon and Somerset Warren, and Gloucester, Salem, Cumberland. And then we have 2 dual county areas, Morris, Sussex, and Cape May and Atlantic counties. So that clinician at the CSA, the care coordinator, would connect with a crisis intervention specialist in the local agency. All of the mobile response programs do sit within mental health agencies. And they will actually give a brief overview of what you've already described so that you don't have to go through that again. You've just told your story, and they're going to relay that and the important details to the mobile response crisis intervention person. The crisis intervention specialist will ask some questions around safety in the community and in your home. So they might ask questions about, say, if you have animals and or weapons, and or anything else they need to know that you're aware of that they might not be aware of, and that really is for planning. They, in each of those scenarios, would be responding and may need to work with you around the plan. So, for instance, when we do training with the staff, we'll talk with them about if someone has a dog and the person that's up to respond might be allergic, maybe they'll shift staff, and so someone different would come. Or perhaps you would be able to put the animal in a different room, or, I mean, just logistics like that. Okay, so they'll ask a few of those types of safety questions, and then they will agree with you on a time. So they're always going to recommend within the hour. We find that works best, truthfully, and let you know or work out with you what time is going to be the best time for you and hold to that as much as they possibly can. And they do respond. These folks that respond, the crisis intervention specialists, they could have a master's degree and be a master's degree clinician. They could have a bachelor's degree in the human services field. They certainly, in some instances, respond in pairs, and sometimes, depending on staffing patterns, they might respond alone. Their teams are a little bit different, and how each county delivers the service is a little bit different in that way. They do respond, just their agency. They do not, as a matter of course, connect with any local law enforcement. They come out in a car. It doesn't look exactly like this that you see on your screen, although that's kind of cute. It's, they vary the way the cars look, but they will just come out. There's really not too much identifying information. They don't have big signs on them that say mobile response. They really kind of try to fly under the radar. There have been instances where they have worked with families who did feel more comfortable in having law enforcement come with them. And they've also worked with families who did not want any part of law enforcement, and they've worked to figure out a different meeting place, because sometimes the families self-identify that there might be too much risk to come at that particular time of day, if they've called in the middle of the night or if there's been a recent incident in the neighborhood, that kind of thing. So they're going to work with you. They really want to make it easiest for you and most convenient. You're already dealing with so much. They don't want to put anything more on you, and that's why we designed the system to come to you. The community response. We've been to libraries and McDonald's and VFW halls and all kinds of places, and we really want that to be driven by what's most comfortable for the family. Most often we do go to homes. We are not office-based at all. Our initial intervention period is 72 hours, and all of your services, or just about all of the services provided within that time period, are by the mobile response agency itself. There is a follow-up up to 8 week stabilization period that's available and that the staff would speak with you about, and that's really driven by your need. So we've been out to families' homes, and they have been very connected to informal supports and services, and they just had an incident. They needed help in the moment, and things were able to be settled down within the 72 hours. All of the important people were connected. There was a new coping skill introduced that the youth was really good at using, and we had been able to close. And then we have times where we go out the first time, and at the 3 hours later we get a call back and we have to go back out, right? Things are just not at the point of de-escalation. Okay, so depending, and if that's the situation at 72 hours and additional supports and services are needed to maintain that de-escalation and move a family out of mobile response and using the informal supports and or formal services that they need, we can provide up to 8 week stabilization period. And during that time frame, mobile response really shifts to more of an oversight program. So they would be connecting families and youth with whatever's identified in the plan. So it might be a formal service, or it might be a local support group, or it could be any number of things. And frequently it's an intensive in community type of program which is a therapeutic program. And the Mobile Response Agency would work with the family and speak with them on an ongoing basis, would speak with the provider on an ongoing basis to make sure that those two parties felt like you were really working towards the goals that we set up, that you all set up with the mobile response staff during their interventions, right? And that progress was being made and that we didn't need to shift the plan. We're going to talk about transition planning in a little bit. That's another piece that they would be working with you and the providers on. We require the mobile response programs to maintain a provider network, if you will. And we wanted them to really understand their community and understand what the supports and services were. They have more formal agreements with some providers, and oftentimes that's our therapeutic programs, maybe our intensive and community therapists. And then some are more informal agreements. Some of our programs really have partnered with outpatient settings who understand the mobile response program and understand the need to oftentimes link and connect quickly with a therapeutic service, but that might be a little longer term than our intensive and community services, which are really built to be short term. Right? And some families really don't want that in-home service, that in-community service. They really do want to go and have time separate and apart from their home environment where they can really work with the family, work with the therapist, with their youth, and make some progress in that environment. So the mobile response agencies will have meetings with their provider network, and they really, on an individual basis, will connect with them as the youth and family are going throughout their service. We're a county-based agency. I mentioned our numbers already, and I mention this again and highlight it because our mobile response in a vacuum would not be as successful if it wasn't that it was within a larger system of care. So we do have family support organizations, and those agencies are staffed by family members who have had youth, who have been through our systems, who have had challenges, who have developmental challenges, who have mental health challenges, who have had to work with the schools around learning needs, and they provide several different services and supports. Anyone in the community can access their warm line information and their support groups. And then they also provide peer-to-peer support for kids and families who are enrolled in our care management organizations. And our care management organizations provide our care management for our youth with moderate and high needs. And our care management organizations provide the care management for kids who have mental health only, who have dual diagnosis with mental health and developmental challenges, and who also just are identified as having developmental challenges. That is something that we worked hard to get to that point. We did have in our transition plan a little different structure, and now we're really glad to be providing one intensity of service in terms of care management for all of our kids. Our family support organizations do have a youth partnership, and that is peer support for our youth. And I also wanted to mention our CIACs, which are Children's Interagency Coordinating Councils. They've been around even prior to our children's system of care structure and have certainly grown and changed over time. Right. And their charge is to bring together at a local level all of the providers and advocates at the local level to look at the system and to see where things are going well and to see where there are gaps that need to be addressed and to make those recommendations then back to the children's system of care. Right. I put this picture up just to show you our system of care continuum. You'll see some things that I have mentioned, a couple that I haven't. There is a component. We have out-of-home treatment as options, and I mentioned at the beginning, certainly we'd like to keep our youth in the home if possible, and we know that in certain instances that's, we're moving to a place where we need that option. Right? Maybe not forever, and for a time being. So that is part of our system, and there's a lot of growth happening in that area in terms of how it's designed and the available options. So I didn't mention some of our, I guess I did mention outpatient as more of one of our traditional services. We do have some outpatient contracts with the children's system of care, but not all of them sit here with our division. And same thing with partial hospital. You see wraparound services there, which I'll mention in a minute. And with our transitions, we've had the opportunity for some new relationships. So, and certainly, it's been a pleasure to meet some folks at the state level from some advocacy groups for kids with developmental challenges. I have gotten to visit a couple of them. I did go up to Mom to Mom, and certainly have worked with Autism New Jersey some, and have certainly spoken with Melanie several times. And I think at the local level it's so important that these relationships are brought to our table, or brought to the kayak, or that we're integrating our arenas so that we make sure we're identifying across our populations served things that can be more beneficial or things that are working well that we can build on. Okay, program structure. To wrap this, to wrap this up a little bit, we do have training. I've mentioned our orientation for mobile response, and we are just starting our mobile response and stabilization services certification process, which I'm extremely excited about. It has several different components, so there is required coursework. There are required competencies that we would expect our crisis intervention specialists to have, and then there's kind of an online review. And all of those things are really overseen by the supervision at the mobile response agencies. All of our agencies have a director and a program coordinator, at least one, and most have multiple. And at least one of those folks needs to be licensed as a clinician. So they are overseen, the staff are overseen by licensed clinicians. So the certification process additionally will have that component. Our trainings, so that's about training for mobile response staff and the required training, and just to let you know that we are moving towards the standard of having this certification process in New Jersey. In addition, and at the end of the PowerPoint, you'll see our website, and the training and technical assistance link is highlighted. There are a number of trainings that have been so helpful to me. There was about 6 years ago, maybe 5 or 6 years ago, a series on dually diagnosed youth that was started. And additionally, there are a number of trainings that are geared for family members. The trainings, any of the trainings are open to anyone, so anyone can attend. And that is a contracted service by Children's System of Care with UBHC. And the assessment tool we use is an information management decision support tool. And the one that the mobile response unit uses is the crisis assessment tool. And it is slightly shorter than our needs assessment and our strengths and needs assessment tools, which are used, the needs assessment really as an initial assessment for our system to identify needs and maybe the best pathway. And then our strengths and needs really is used by our care management organization and our out-of-home treatment settings to show progress over time and really assess the ongoing needs and how they're changing. So the crisis assessment tool, and what you might expect if a mobile response person was in your home, they would be asking some questions in these areas, right? And so you'll see it's not dissimilar to the triage process that I mentioned, right? That is a very short process at the front door, and then this, the goal of getting mobile out there is get them out there quick and then gather more information. And so you'll see information asked in these same areas, including life domain functioning. There's juvenile justice risks and child protection as well. And we did do some work on the tool with Dr. John Lyons, who was the developer of the IMDS tools. We added some questions around developmental stages and challenges, medical physical challenges, and just status and substance abuse information at the time of our transition. And those modules can do a few things. So they're attached to most of our assessment tools. For the CAT, it really can let us know if we need to begin to access additional evaluations, either ones that have already been done to start looking for them, or connecting to the school to get them, or connecting with the family to ask about them, or if maybe they haven't been done and we need to make those linkages and get appointments for that specific set of information. And it also helps us understand that those are needs, and that for any piece of our tool, our CAT, the goal of getting the information is really to identify the top needs, right? Because I know mobile response, it's a short-term service, and we won't be able to address every single need, but we can begin with the top priorities that you identify. So we understand those, and then we use them to work on the treatment plan with you. We spend a lot of time with mobile response talking about engagement. That's so important to me and to instill in the mobile response staff, that really listening to your family story is where they're going to get so much information, just listening and understanding what it's like to walk in your shoes. And we really want that to be the first focus, that relationship, right? That's the most important thing. And we spend a lot of time in training talking about the system of care values and principles. From a practice standpoint, right, we should see these principles inherent in our treatment planning and in the care that your family and your youth are receiving. Certainly the ones centered in yellow, they're our primary focus. We talked about community ties already, mentioning culturally competent. You know, actually, I mean, really every family is very individual. Really understanding from where they're coming and having that context is so important, because your background looks different from my background and your values, and it's important for the mobile staff to be able to recognize your family's values and your youth's perspective culturally, and really be able to set aside any kind of beliefs that they have, and to focus on bringing to you what you need. And then certainly, if I haven't said it already, it's coming up in the next slide. You're the expert on your youth and your family. And we're not a full child family team meeting model like our care management organizations are. And we, as a mobile response unit, really try to make our collateral contacts and pull together information from a lot of arenas. And even though we might not all be sitting at the same table over time, but to really partner with everybody to make the best outcome possible. And you and your child, you are a driving force in that process, right? And working together with the mobile response intervention specialist can really move you in the direction that you want to go, by us listening and understanding all the things that you've been through, all the things that you've tried before, what it is that your goals are for yourself, what outcomes you want to achieve. And then around our core principles, you can see are our wraparound values, right? Things that, especially in terms of mobile response, being flexible, right? So things don't always work the first time, and we have to go back to the drawing board. And I think that's a really important lesson, and just in persistence and trying again. You know, there's 15 ways to approach any kind of challenge, and we might need to think of a 16th, and that's okay. Needs driven. I'm going to talk about contexts in just a little bit. We really want to understand, and I mentioned this at the beginning as well, what are those needs? What's going on in your life? If we kind of address only the symptom, we might have some progress for a little while, and if we can get to the underlying needs, then we might have some progress for a little more ongoing time. We do want to think about outcomes, right? How do you want things to look differently for your youth, right, when mobile response is phasing out? How do you want things to feel differently for you when when the next steps come? I won't go over every one, but please feel free to ask questions if you'd like when we get to that point. Okay. So continuing with the program response, in terms of de-escalation, just by being there, we'll kind of interrupt some of the dynamics that are going on, right, if you bring something new to a situation. And the mobile response staff are going to really work with you as the family to understand what a typical day is like. How do you want things to look? What's the environment like? We find that we talk about kind of 4 areas of crisis triggers, and interpersonal, environmental. I am going to forget the other 2 as I'm talking, but I wanted to focus on the environmental and the interpersonal dynamics. The environmental, sometimes it might be as simple for some families as kind of going in and realizing that there's a lot of different things on really loud, of TV and a radio, and turning them down to really kind of refocus families. Sometimes it's not that simple. So, but we do ask them to look at the environment, because most frequently that might be one of the easier things to impact in terms of change. We talked a little bit about our assessment tool. That's our communication mechanism, and how we then work to move towards a treatment plan with the family. Our assessment is a little bit larger than that. So the crisis intervention specialists would be working with you all to identify strengths of your youth and strengths of your family. It's not the most natural place for families to begin when they're in the midst of a crisis. Tell me what you like about your kid. And so we have to ask intentionally to think about that and realize how hard it is to have reached out for help in this situation, and that you guys have been through so much to get to that point. So we do need to understand even prior to asking about strengths, because we do know it's hard to get there in a crisis situation, and it can give us our best in terms of outcomes if we can link our strategies to something that's already a strength of our youth and families. They'll be talking with you about triggers, so walk me back. Tell me what happened before that. Tell me, what happened this morning. Was it a typical morning? Things like that. Communication, right, for all of our kids, and I know in particular I've heard so many stories since we had the transition of kids from DDD about communication. It's one of the first questions I ask if someone's having a challenge in working with a family is, so how do they all communicate? And if the youth is not verbal, then how do they communicate? Do they have a system? Do they have access to a system? And it's amazing the variety of answers that I'll get back. And so that has been one thing when mobile response staff have focused on that they've really been able to make some headway in making sure that there's a communication method that's accessible, available, that everybody's agreeable to. Not necessarily even always the easiest thing to get to, but really has been helpful in a couple of instances. I mentioned context, another of the first questions that I think about asking is in terms of medical component. And this was actually built into our training even prior to our transition, excuse me, and just how our medical pieces can mimic some mental health symptoms sometimes. And speaking of communication, when we do have challenges with communication in terms of getting our needs met, if we are having some pain, really being able to identify that isn't easy. So that's another question that we ask pretty up front. And to that end, just a brief story. We had a family whose young person couldn't communicate verbally and was seen to even be, wasn't eating very well and just was having all kinds of complications because of that. And folks were thinking about it in the behavioral realm. And after much persistence on the family's part and on the mobile response staff and everybody involved, they were able to identify that there really was a medical condition that was painful when the young person was eating. So it caused a whole different trajectory, pathway for that young person in terms of treatment, and take a look at kind of the behavioral plan that was in place and in light of the medical context that had been identified. Right. And so I won't go into each one of these, but these are trauma. I would be remiss if I didn't mention just the rates of trauma for our kids, right, as we're a sister division to DCP&P, and for our kids with developmental challenges, and that sometimes aren't able to communicate about it or have a perceived trauma that we may not even identify. It's kind of like when a family defines crisis, right? It's really a perception of trauma sometimes. So we ask our mobile response staff to really be mindful of that experience and then to really understand how symptoms of that trauma might manifest themselves and might look like other things in terms of behaviors, in terms of mental health symptoms. All right, planning. I mentioned our individual crisis plan. So one of the outcomes of the initial response will be a safety plan, and we do a couple of different types of plans. So the safety plan will be concrete, and most agencies leave a copy with families, and that can go right on the refrigerator or wherever is convenient for you, because in a crisis our thoughts get disrupted and it's hard to remember stuff. That's just proven, right, and the way our bodies work. So they'll leave that concrete plan. The individualized crisis plan is a little more detailed and shows more of the linkages and connections that the family would be working with over time. And our transition plan, that starts at the front door, anticipating your needs going forward, right, so that they can begin, the staff can begin referring to where you're identifying that you might need after mobile response goes. Excuse me. The planning involves looking at desired outcomes and pathways or strategies to get there. And again, that's really linked with the strengths that family and youth can identify. And then I mentioned the role of mobile in terms of looking over that and monitoring that plan and the providers and the services. Okay. This is just, I wanted to pull it in so you could see some of the information that you'll be talking about. The mobile response staff might be looking to get information from you and make suggestions in terms of the family crisis plan, the concrete one, the first one typically that's done. And that's right, just how do we define the crisis? Strengths and interests to be used in a crisis, right? They'll be asking about how do you know when this is about to happen, or what are some of the triggers? We can get to that by kind of stepping back in time. In terms of who and what helps, I think that's frequently our training staff have family members employed who do the training, some of the trainings, and they have youth who have been through our systems as well. So one of the things that I've talked about frequently with a couple of them in terms of who and what helps, and I've experienced this in my own life, right? I have people who I can go to, and kind of over time, I feel like I've exhausted them. So sometimes what's really helpful is just getting reconnected, right? Sometimes it's let's find a new connection because we do have families and that's where we're starting, right? We need to find a new connection, but oftentimes we have families who have built-in supports and resources, and because it's hard and because this is ongoing and daily, in terms of reaching out, feeling comfortable doing that, or feeling like the person who's a resource will be willing to help is a challenge. So that's oftentimes where one place that we're able to be helpful. You'll see established consensus with the family on plan, right? So if you will, I pulled these slides in I wanted to demonstrate for you all some of the things that we talk about with the mobile response staff and orientation. And the consensus is really important. The plan it could be the most beautiful plan, and if it's not going to work for you, and if it's not going to be something that you're willing to do, it's not going to work, right? It's not about us writing a beautiful plan. It's really about what is going to work for you, things that you're going to be able to do that seem reasonable, and really setting goals that are reasonable as well. Like I said, mobile response is short-term and time-limited, and we know we can't tackle the world, and we can start on a pathway, right? So the individual crisis plan builds on the family safety plan. Okay? It's a little bit more detailed, and it starts to identify more supports and services that are going to be implemented over time. The family safety plan most likely will have, I'll just flip back to that, hopefully some more concrete ideas that you can use the minute the mobile response person leaves, right? Maybe something to shift in the environment, or a new coping skill. They have different worksheets, or they work on, self-regulation, right? They might introduce a way of breathing, or just a different way of communicating, or waving, or whatever works for you. Taking time out. I mean, things that might seem reasonable or simple, and that some folks really in the heat of the moment aren't identifying as an opportunity. And then the individualized crisis plan would be a little more of the longer-term vision for the rest of the time that the family is with mobile response. I mentioned already collateral contact, so that's really what collaboration is about in terms of coordination of supports and services, and wanting you to identify who's important in your world, and allow us to talk to them or with them to get their perspective, and to be able to see how they might be able to bring resources to the table. I mentioned 321 contact. I've mentioned informal supports a few times, so I like to think about 321 contact in terms of really building for the informal and the natural supports at level of 3 or 2, and then maybe the more formal supports 1, because our goal is really to have you not be reliant on the system if at all possible, and those more formalized supports when you don't need them. Certainly if they're needed and beneficial, we're not looking to do that, but just from a perspective of what's able to be maintained and what's available to you over time. And then contact would be, specifically, we're looking for mobile to make sure everybody has the right information, phone numbers, and specifics around those services and supports that you've discussed. And I say linkage and connection. We really would prefer to see that connection when at all possible. You've had an appointment at the time of transition, versus just kind of being handed a telephone number. We're really looking more for the connectivity piece. Sometimes it's not possible given wait times depending on where you are, and that's really would be the goal. I just wanted to mention, I know I'm just being mindful of time, family support services, that is access through the CSA. Mobile response can certainly call with you if that's something you need. Intensive in-home services, Mobile Response has access to the clinical side if you and they feel the behavioral piece would be beneficial, you and they would be looking to transition you and the youth to care management organization. And DD eligibility Mobile Response has also helped in terms of gathering information and pulling that together with families. Stabilization management, you can take a look at this after it's posted, and just in terms of some of the things that happen in the 72 hours also happen in the 8 weeks. And it's driven by your needs, whatever you need. If you need additional face-to-face visits, that's certainly possible. I wanted to just give you some information on program funding. You can kind of look at this and see. I mentioned paperwork as just one of the components Mobile's responsible for, and the presumptive eligibility process. We do ask families to apply for Medicaid. You do not have to be eligible for Medicaid to receive the services. It just allows us to maximize our funding so that we can serve as many people as possible if you just apply. And they will work with your third-party insurance. Sometimes they have different services available to you all that we might not offer, and so they could certainly help coordinate that. Here's a few examples of some successes. I could list them all. These were the first that came to mind. Monmouth Mobile has just had a wonderful response and really developed things very quickly to be helpful in terms of working with kids with developmental challenges at a different rate. Certainly we had before, but not at this rate since the transition and now integration. Union Mobile Response did as well. Just a wealth of information that their staff person was able to bring to the families, and they were gracious enough to let him train some of us. And Ocean was able to identify some ABA providers pretty quickly who really had some success in a short-term chunk of time. Right? So I did list some program and system outcomes. Perhaps our most, the one we're most proud of is the maintenance of living situation. And I'm sorry I didn't get to pull more recent data, but that was as of January, and it fluctuated between about 94 and 97% since our inception in around 2001. So Melanie, I realize I've just about used up all the time, but I would be happy to take some questions.
Oh, perfect. Wendy, thank you so much. I think the information offered has been outstanding. And I know that we actually hit capacity for the webinar. So if anyone knows someone who is not able to access the webinar due to capacity being reached, we will definitely be able to send them a link so that they can listen to this presentation and also receive the benefits of the information that Wendy had shared with us today. Wendy, I want to start by, again, thank you for really pointing out that a crisis is defined by a person or family that is experiencing that crisis. So again, thank you very much for pointing that out. I think different families, whether you're a professional family member, I think we identify that point of crisis different ways. So again, thank you for that. And we do have a lot of questions actually coming in. So we try to sort through as many as we can, and if your question is not addressed, we will by all means do our best to get back to you to address that need. So Wendy, the first question is going to be, would you know if there are plans for this service, this much needed service, to be extended to adults?
Oh, that's a fantastic question, and I honestly do not know of any plan to or not to extend the service to adults. I do know that the designated screening centers have some outreach capacity, but I don't know if there's any plan to have a service more like this.
Perfect. And again, if that's information that we become aware of, we'll definitely try to disseminate that also. Wendy, would you be comfortable if we shared a copy of your PowerPoint? We do have a lot of families asking.
I believe so. I don't see why not.
Perfect. So I'll touch base with you after the webinar, and if you're comfortable with that, I'll make sure to send a copy to everyone who registered for this session. And I know that you had mentioned the free online trainings, I believe. Do you have an email link that you can send that we can also include to the registrants for that link?
I can, and it's also the last slide
Okay.
on the PowerPoint too.
Perfect. Is that the one that's brought up now?
Yes.
Okay, great. Perfect. So I'll also include that in the email. Wendy, is there medical insurance that's needed to access these services? And if not, is there a fee involved?
There is not medical insurance that's needed. We do require that families apply for New Jersey Family Care or Medicaid through our presumptive eligibility process. So that means the mobile response staff will ask them questions about your household composition and your income. It feels a little intrusive. So once they do that piece, whether you are eligible or not, this service is available. If you are not eligible for the New Jersey Family Care or Medicaid, the resources are funded by New Jersey state-only dollars, and that is not charged to you.
Perfect. So, Wendy, can you explain a little bit, can a school staff contact you if a parent gives permission?
The school staff may call Perform Care at any time. However, the parent needs to give verbal consent while that phone call happens. So sometimes we have schools call and then the parent will be conferenced in to give the consent, and then mobile can be dispatched and say to meet at the school. Maybe the parent is on their way or something like that.
Okay, but a parent should be there during the meeting, correct?
Honestly, that's the best way that our service is delivered. However, we have flexibility. So if the parent or guardian can give verbal consent, then mobile can dispatch. Say the parent is several hours away. They can dispatch to the school, and they can then, they can dispatch to the school, the parent can meet them there, or they can dispatch to the school, and then the mobile response staff can go out later to the home and meet with the parent. But I think it's usually best if everybody's together, but there is flexibility there in the model.
And that's also an option if the student is not registered with DCF?
Yes, the parent would need to, again, give verbal consent to register the youth and for the service, but they don't have to be pre-registered, so to speak. It's available for a first-time caller, just as it is for somebody who's called at a time.
Perfect. I'm sorry about that background noise. And Wendy, can you tell us if the Family Crisis Intervention Unit and the mobile response merged in Monmouth County? Would you have that information?
It is not merged in Monmouth. They're combined units. We call them in Passaic, Sussex, Cape May, Middlesex, Mercer, Hudson, Gloucester, Salem, Cumberland.
Thank
I think
you.
I hit them all.
And you know, we seem to have gotten a lot of questions in regards to making that initial contact for mobile. And again, I just want to make sure that everyone's clear on that as long as someone else can contact mobile, as long as the parents are given that verbal permission to mobile, correct?
Yes. So, for instance, you can't necessarily sign something for the school that gives them blanket to access mobile response service, but the school can call and conference you in to agree to the service so that you don't necessarily have to be on site when the call is made.
Okay. And can you let us know, a needs assessment, can it be conducted at the school rather than in the home if the parent is present at the school?
A needs assessment. That's an interesting question. I don't know anything that prohibits it. It's a community service, So I know that the regulations prohibit anything happening in an office setting. So I don't know of anything in the regulation that says that a needs assessor couldn't use a room at the school, I guess. Am I answering the right question?
I believe so, yes.
Okay.
And Wendy, is there a benefit of getting connected to mobile through Perform Care rather than calling mobile directly?
Actually, the only way to access mobile response is to call through Perform Care.
Okay.
If you call the mobile agency locally, they will connect you with Perform Care in order to make sure that that the youth is registered and that the service is authorized. They do require a pre-authorization, which really is just meeting the criteria that we described.
And I'm going to give you 3 more questions if you don't mind
Sure.
being a little late with me. Once a family is with the CMO, can they still access mobile response for future needs, or do they need to go back to the CMO if a crisis presents?
That's a great question. The care management organizations develop family crisis plans with all of their families and youth. So the first thing they ask for their families to do is to get in touch with them, and they should be helping the family to work through that family crisis plan. So if at the end of that family crisis plan, we still need another set of eyes and de-escalation or something, then the CMO and family will call and get mobile response. I will tell you, if a family calls the CSA and they're enrolled with mobile, the first call will be to the CMO to let them know. And then if there isn't response from the CMO relatively quickly, then the CSA will dispatch mobile, and mobile will coordinate locally with the CMO. So the answer is yes, mobile can be accessed, and the rest of the answer is that for coordination and service reasons, I guess, and support reasons, I think the best thing to do is coordinate with the care management organization initially.
Okay, and I know that you mentioned that mobile tries to be at the location within an hour of getting that phone call.
Yes.
Can you offer some clarity to mobile coming into the environment if there is an escalated behavior at the moment?
Some clarity around when they may not. So I guess our limit is if there is an imminent risk to the youth or the family or someone else. So that's kind of intent to do harm with means and a plan and intent or some recent action, then that call would be triaged at the CSA. They would connect that person with either the law enforcement, right, to get them to a medical facility or psychiatric emergency screening center.
Okay. And I'm going to give you one last question, if you wouldn't mind.
Sure. Can I just add one thing about the CMO?
Oh, please.
So mobile response can be dispatched. They are limited in terms of the services they can provide. They can only provide the 72-hour service. They are prohibited from providing the stabilization management, since the care management organization is really providing that.
Okay. Okay, perfect. I think that offered a lot of clarity. And the last question is, what if someone is receiving services and turns 21? Will those services continue?
In terms of the mobile response services, so what we like to see from a place of practice is a good transition plan. So because a youth turns 21 today and they have 4 more weeks of stabilization management services to go, we don't just say, well, sorry, you're 21, we'll see you. From the beginning, the hope is that there's been a transition plan working toward that point, that maybe some of the discussion about transition back to adult services might have already happened. But so that, is that clear? Like it won't stop that day.
Okay.
It can continue until the transition plan is set within the parameters of the service, if you will. So we wouldn't be extending, say a year. We don't do that with mobile programs, but certainly we want to see what's best for the youth and family in terms of connection.
Wonderful, wonderful. Thank you so much. And again, I do just want to let everyone know that I will be able to provide this session if someone did miss any part. And Wendy, if you're comfortable, again, we'll forward the PowerPoint and along with that link so families and professionals can both access that information. Again, on behalf of the Family Support Center of New Jersey, Transition Matters of New Jersey, Wendy Davis from the Children's System of Care, and us, the staff from the Family Support Center of New Jersey. We would like to thank you for joining us this afternoon. Please feel free to explore future trainings and webinars at transitionmattersnj.org. Some of our upcoming topics include independent living skills, preparing young adults for life on their own, and the impact of family dynamics on child behavior. If you're interested in listening to this session again or any of our past webinars, you will find all archive sessions on the fscnj.org website under the category of training and events. Or please call us at 1-800-372-6510 for further assistance. Wendy, thank you again. I think that this was vital for many of the families just to have a better vision of what this service may look like, and I think it was a wonderful support that you offered. So thank you so much.
Thanks for the opportunity, Melanie. I appreciate it.
Thank you. Have a great afternoon, everyone.
Okay. You too. Bye-bye.